So after the discussion of anterior circulation stroke, we will now embark on the posterior circulation stroke. And as we have discussed, the posterior circulation contains the vertebral arteries and one basilar artery which divides into two posterior cerebral arteries. So this segment we will start the vertebrovascular system syndromes or the posterior circular syndromes one by one. In the first segment, we will first start with posterior cerebral artery syndromes or posterior cerebral artery stroke localizations. So जो हमने पहले से मालूम है और थोड़ा अभी पोस्टीरियर सर्कुलेशन के बारे में, पोस्टीरियर सेरेब्रल आर्टरी के बारे में विविड डिस्कशन करेंगे कि हाउ वी विल गो अप्लाई आवर एनाटॉमिकल नॉलेज एंड द सिंड्रोम्स रिलेटेड टू द पोस्टीरियर सेरेब्रल आर्टरी. ओके, so we are now talking in this segment only about the posterior cerebral artery. So now we have already we have discussed the basilar artery. It divides into two posterior cerebral arteries. We will stick to the common things. 80-90% of the persons, the basilar artery gives rise to posterior cerebral artery. And if you remember in the internal carotid segment, I had told there are some situations where the posterior cerebral artery, the precommunal part is atretic, so the posterior cerebral artery may arise from the internal carotid artery. We have discussed in internal carotid artery. We are not going to discuss this rare phenomena. We will talk about common things. So majority of the cases, 90%, the basilar artery divides into two posterior cerebral artery. Now, we know about the posterior communicating artery, which is a connection between the internal carotid artery to the posterior cerebral artery. So now, at this level of communication of posterior communicating artery, this is the posterior communicating artery, internal carotid artery. So, from the basilar division up to the communication of posterior communicating artery, this is known as P1 segment of the posterior cerebral artery. And distal to the posterior communicating artery is the P2 segment. Now understand here, the P1 segment basically supplies to the midbrain and the tracts within the midbrain, important structures within the midbrain. So this is a midbrain. This is the ventricle. So this is the third nerve nucleus. This is the red nucleus, and these are the cerebral peduncles through which the corticospinal tract travels. Basically the midbrain and thalamus and subthalamic nucleus. This portion is supplied by the both P1 segments, and also there are small penetrating arteries which I have already discussed. Perforators, small penetrating perforators, they also arise from the proximal segment and they also supply to the thalamus and brainstem structures. Another interesting point is, in some cases there is another artery which arises from the P1 segment, only one side P1 segment. This large artery, it traverses to the opposite side, giving rise to penetrating branches to both thalamus and midbrain perforators. This is known as the artery of Percheron. Artery of Percheron. This is one artery. See, the important thing is here is only one is going to opposite side. It is supplying bilateral. Bilateral it is supplying. There is no another artery from here. So this is Percheron. So if now the P2 segment is dedicated to occipital lobe and medial temporal lobe. So concluding, P1 segment, midbrain, thalamus, subthalamic nucleus, P2 segment, occipital lobe and medial temporal lobe. So first we will talk about P1 segment. We will divide P1 segment occlusions into these segments. What will happen if only one P1 segment is occluded? Next, what will happen if bilateral P1 segment are occluded? What will happen if there is a occlusion of the artery of Percheron? And what will happen if only the perforators are occluded? And last but not the least, I will discuss it separately. Tip or top of basilar artery occlusion. What will happen if that will be discussed last? First, what are the P1 segments? Starting with P1 segment occlusion, what will happen is first, ipsilateral, on the ipsilateral side there will be third nerve pulse. That is, eyeball will be down and out, midriatic pupil not reacting to light, ptosis. And on the contralateral side, contralateral hemiplegia. So ipsilateral third and contralateral hemiplegia, clinical feature of P1 segment occlusion, unilateral. Ipsilateral third, contralateral tremors, cerebellar ataxia, hemibalismus. So, ipsilateral third, contralateral involvement of the cerebral peduncle and sometimes the corticobulbar fibers for the face. There can be hemiplegia and facial paralysis also. Contralateral facial paralysis, supranuclear facial palsy. So, facio-brachial and crural hemiplegia, ipsilateral third nerve. This is known as crossed paralysis. Now we are in the brainstem syndromes. When we talk of brainstem syndromes, they are classically characterized by cranial nerve involvement on one side and contralateral hemiparesis, or involvement of other structures apart from cranial nerves, including cranial nerve, other structures we will go ahead when we discuss pons and medulla, and contralateral hemisensory loss. So this is known as crossed, कुछ finding इधर, इसलिए crossed paralysis. So ipsilateral third, contralateral facio-brachiocrural hemiparesis, corticobulbar and corticospinal tract involvement through the cerebral peduncle, third nerve गया and red nucleus अगर involve हुआ तो contralateral tremor, subthalamic nucleus अगर involve हुआ contralateral side में hemibalismus, tremor, hemibalismus, cerebellar ataxia. Cerebellar ataxia क्यों? क्योंकि red nucleus itself can cause ataxia, and ataxia can also be occurring due to certain fibers which are known as dendrothalamic tract fibers. They have connections through the thalamus to the cerebellum. So there will be cerebellar ataxia. They come by different names. Say for example, ipsilateral third contralateral hemiplegia is known as Weber's syndrome. Ipsilateral third with contralateral cerebellar ataxia is known as Claudi's syndrome. Ipsilateral third contralateral hemibalismus, Benedict syndrome, or movement abnormalities, Benedict's, D-I-A-T-S, Benedict syndrome. So various syndrome के नाम पे आता है. So this will happen if there is a P1 segment occlusion. Now if there is bilateral P1 segment occlusion, it's a dangerous situation. So catastrophic situation. So midbrain, thalamus, everything is gone. Bilateral P1 segment occlusion. How the patient will present? Patient will present is coma. Bilateral cranial nerve in form of third nerve palsy. Can be ptosis. Irregular pupil, dilated pupils, bilateral spasticity, extensor plantar quadriplegia, and decerebrate posturing. So bilateral P1 occlusion can lead to coma, irregular pupils, bilateral long tract signs, corticospinal tract signs, and decerebrate posturing. The legs will be extended in this comatose patient. When you give a painful stimulus, the legs will be extended all the more, tight हो जाएगा, and the arms will go like this. Okay? Pronator, extension and pronation, and wrist flexion and pronation. This is because of involvement of red nucleus. The dharma of red nucleus is it causes flexion of the upper limbs. So anything, the lesion, if it is red nucleus or below red nucleus, this is known as red nucleus cannot do this. There will be opposite movement, decerebrate posture. So these are the cardinal signs of bilateral P1 occlusions. Now next coming to artery of Percheron syndrome. If there is a artery of Percheron involvement, all are more or less same situations. I have told you this Percheron artery is a branch of this. This is P1 segment. Percheron artery goes like this to the opposite side, and also it gives rise to perforators to everywhere. So again in Percheron syndrome also, if one side Percheron is gone, everything is gone. So this patient will also present as coma or stuporous condition, stupor, coma, and bilateral upward gaze palsy. Upward gaze palsy. Inability to look up, drowsiness, and sometimes abulia. Look here, abulia was a frontal lobe sign. We had discussed abulia in anterior cerebral artery circulation, frontal lobe sign. But again, abulia comes in the second spot as a artery of Percheron infarct. So again, thalamus, subthalamic nucleus, brainstem, midbrain, they have got their frontal lobe connections. So a lesion here can also manifest as profound abulia, stupor, coma, bilateral upward gaze palsy. It is Percheron syndrome. Now, if there are only perforator occlusions, so there is no major catastrophe. Only perforators are involved. If there is a perforator involvement, then classical lacunar type of syndromes occur, like a classical syndrome of a patient will present with sensory loss, pain and temperature sensation on the opposite side of the body, starting from the face to the whole arm, trunk, contralateral lower limb. This is due to involvement of the thalamic perforators. So this is very peculiar, mathematical. Patient will tell that there is sensory loss. No motor loss maybe, but sensory loss and tingling sensation. Later on, these tingling sensations become so positive, the patient is restless and there is severe pain, burning, tingling, as if acid has been poured on the patient's face to the one side of the body. This is known as Rouse's thalamic syndrome. So this is a perforator syndrome, contralateral face, body, limbs, pain and temperature loss, anesthesia से hyperesthesia तक, extreme painful situation. These are the perforators. So this ends the P1 segment. Now P2 occlusion, I have already told you, occipital lobe, medial temporal lobe are the culprits, or they are the sufferers. So if there is unilateral P2 occlusion, what will happen? Occipital lobe गया, medial temporal lobe के features आएंगे. So unilateral P2 occlusion में क्या होगा? Very characteristic manifestation. Contralateral homonymous hemianopia without macular sparing. Homonymous hemianopia without macular sparing. Macula यहाँ रहता है. It's not like this. It is important to discuss it here. That's why I am discussing. ये एक सिचुएशन है, ये भी होमोनिमस हमें है, लेकिन मैकुला इज स्पेयर्ड, सेंट्रल विजन इंटैक्ट, मैकुला स्पेयर्ड. This occurs in a case of middle cerebral artery territory infarct, contralateral homonymous hemianopia पढ़े थे अपन, लेकिन वहां पे मैकुलर स्पेयर हो जाता है. क्यों? मैकुला इज सप्लाइड बाय द P2 सेगमेंट ऑफ द पोस्टीरियर सेरेब्रल आर्टरी. लेकिन अगर P2 सेरेब्रल सेगमेंट ऑफ द पोस्टीरियर सेरेब्रल आर्टरी इन्वॉल्व हुआ तो उसमें मैकुलर स्पेयर नहीं होगा. तो विदाउट मैकुलर स्पेयरिंग कॉन्ट्रालैटरल होमोनिमस हेमियानोपिया. सेकंड, मीडियल टेम्पोरल लोब पे एक एरिया है हिपोकैम्पस. मेमोरी, हिपोकैम्पस इज रेस्पॉन्सिबल फॉर द मेमोरी. So what will happen is sudden loss of memory, retrograde amnesia, sudden loss of memory. Okay, to recent things, recent memory, sudden loss. क्या बोलते हैं उसको? ट्रांजिएंट ग्लोबल, कुछ नहीं याद रहेगा, एमनेजिया. ट्रांजिएंट ग्लोबल एमनेजिया हो जाएगा. अगर डोमिनेंट हेमिस्फीयर में गया, अगर डोमिनेंट P2 गई, डोमिनेंट ऑक्सीपिटल लोब, मीडियल टेम्पोरल लोब गई, तो डोमिनेंट हेमिस्फीयर इन्वॉल्वमेंट में सडन भूल जाएगा आदमी. ट्रांजिएंट ग्लोबल एमनेजिया, इंपॉर्टेंट इज ट्रांजिएंट, हमेशा के लिए नहीं रहने वाला, जल्दी रिकवर हो जाएगी. Memory will recover. Why? Because memory is bilaterally represented. It's not a unilateral representation. Okay. So contralateral homonymous hemianopia without macular sparing and transient global amnesia. अभी कभी अगर ये एरिया इन्वॉल्व होता है, यहाँ पे स्प्लेनियम, कॉर्पस कैलोजम, स्प्लेनियम ऑफ द कॉर्पस कैलोजम, ये स्प्लेनियम ऑफ द कॉर्पस कैलोजम अगर इन्वॉल्व हो गया तो एक क्लासिकल सिचुएशन होता है एलेक्सिया विदाउट एग्राफिया. पढ़ना जो पढ़ रहा है, पढ़ने के लिए तो समझ में नहीं आ रहा है कुछ, लिखने के लिए बोलो, डिक्टेट करो, बुक डिक्टेट कर लेगा, पढ़ नहीं पाएगा. लिख लेगा, डिक्टेशन दो, लिख लेगा, पढ़ने. एलेक्सिया विदाउट एग्राफिया. तो स्प्लेनियम ऑफ द कॉर्पस कैलोजम इन्वॉल्वमेंट ऑन द डोमिनेंट हेमिस्फीयर यूजुअली विल गिव राइज टू दिस काइंड ऑफ प्रेजेंटेशन इफ देयर इज ए पेरिफेरल P2 occlusion. और क्या क्या हो सकता है पेरिफेरल P2 occlusion? Inability to recognize familiar faces. Familiar faces recognize कर नहीं पाएगा, facial recognition center चली जाएगी. तो prosopagnosia, visual object agnosia, कोई ऑब्जेक्ट दिया, visual object agnosia, prosopagnosia, inability to recognize familiar faces. Okay. Peduncular hallucinosis, zigzag lights, bright objects suddenly hallucination जैसा आएगा विजुअल फील्ड में. So hallucination, these are the features of P2 occlusion, unilateral P2 occlusion, unilateral P2 occlusion. Now we will talk of bilateral P2 occlusion. If bilateral P2 occlusion हुआ तो both side coronal section में अगर लिए तो both occipital lobes gone. तो cortical blindness. Now what is this cortical blindness? Patient is blind. Patient will not see anything. Patient is blind. But when you examine the eyes, everything is fantastic. Pupils are fantastic, reacting to light, round, normal size, reacting to light and accommodation. Patient is seeing nothing. That is known as cortical blindness. Due to calcarine sulcus infarct bilaterally. Now, if it is associated with the visual association areas which are around the calcarine sulcus, area number 17, area number 18, area number 19, association areas. The patient is blind, but he is not accepting that I am blind. He is denying the blindness. He is saying I am fantastic, I am fine. But on examination, he is falling, rumbling, he is not able to recognize. So, that is known as Anton syndrome. So, same signs, again pupillary signs are intact. Patient is denying blindness, patient is blind. Cortical blindness, Anton syndrome. Another interesting syndrome which occurs is known as Balint syndrome. Balint syndrome. What is this Balint syndrome? It characterizes three things. One is optic ataxia. What is this optic ataxia? Is patient's eyes are normal. Patient is seeing everything clearly. Patient is not having any psychological illness. Patient is not having any ataxia or apraxia, cerebellar signs, so that he is not reaching intention tremor. Nothing is there. Sensory system normal. But when you say everything is fine, he is looking at things, he is seeing. When you ask the patient to go to a target, he misses the target. He tries that as if the target is here. See, there is no intention tremor. He feels that the pain is here. Or say for example, he sees the pain is here. और नीचे है, डेप्थ परसेप्शन इज गॉन. कहाँ पेन है दिख नहीं रहा, सब दिख रहा है लेकिन यहाँ पेन है क्या, यहाँ पेन है क्या. सो ऑप्टिक अटैक्सिया. हैंड कोऑर्डिनेशन विद द विजुअल ऑब्जेक्ट इज गॉन. नो इंटेंशन ट्रेमर्स, रिमेंबर, नो सेरेबेलर साइन. दिस इज सेकंड. ओकुलोमोटर अप्रैक्सिया. oculomotor apraxia. What is this? When I am looking at a scene or a scenario or a scene, I am analyzing everything at a, even if I am looking to the center, I know that somebody is here, a blackboard is here, everything is here, there is a room. So I am standing here, I can describe there is a black sheet, there is a central blackboard, there are two sheets, there is a thing here. So I can analyze everything. Say for example, give a scenery. I can look at the scenery, I can see that here is a beautiful drawing of hills, sun rising, there is a river flowing, there are trees, there is a village. Everything I can analyze from a picture. But this person, oculomotor apraxia, he just sticks to one point. He cannot gather the separate information from a bigger picture. Okay? And there is loss of movement of the eyes. There is no ophthalmic paralysis, there is no ophthalmoplegia, but it will take time to look from one side to another. फिक्स है जितने सा एक से देखने के लिए टाइम, हम तुरंत देख रहे हैं, ऐसे देख रहे हैं, वो देख नहीं पाते, धीरे धीरे देख रहे हैं. Oculomotor apraxia. And lastly, simultaneagnosia. Again, it is same. It is the higher literature conversion of the oculomotor apraxia part. That is simultaneagnosia, means simultaneously I cannot gather information from here. I will see the smaller picture always, not the bigger. A beautiful literary term has been coined to describe this simultaneagnosia is missing the forest for a tree. अगर मैं किसी को खड़ा कर दूंगा यहाँ पे और आगे फॉरेस्ट है, ये एक पेड़ है, किसी आदमी को पेड़ के पास जाके चिपका दो, मुंडी पूरा चिपका दो, आंख खोलने के लिए बोलो, कुछ फॉरेस्ट नहीं दिखेगा, सिर्फ उसको पेड़ का ट्रंक दिख रहा है. सो इट इज मिसिंग द फॉरेस्ट फॉर ए ट्री. से फॉर एग्जाम्पल अगर एक टेबल लैंप है तो वो क्या कर रहा है, एक ही पॉइंट में सिर्फ टेबल लैंप का बेस को देख रहा है, तो उसको लग रहा है एस्ट्रे है. ही इज मिसिंग द टेबल लैंप पैड. ओके, सो उसको बोलते हैं एसिमुल्टेनियस. तो दिस इज ए कंपोनेंट ऑफ बैलेंट सिंड्रोम. देयर इज ए टेस्ट टू डिटेक्ट एसिमुल्टेनियस. देयर इज ए, कैसे टेस्ट रहता है, एक शीट रहती है, एक शीट में बड़ा ए और छोटे छोटे ए, बड़ा ए छोटे ए लिखते हैं और पेशेंट को बोलते हैं जहाँ ए है उसको राउंड करो, क्योंकि पेशेंट एक ही बार में बड़ा ए का सिर्फ इतना पार्ट देख पा रहा है, तो सिर्फ इतने पार्ट में अगर ए आ गई तो उसको राउंड करेगा वो. विल ओनली राउंड small a's because it is coming under the small scanning area of the visual, and this large a's he will miss. This is the test for asimultaneagnosia. And sometimes what happens, apart from all this cortical blindness, Anton syndrome, Balint syndrome, optic ataxia, oculomotor apraxia, asimultaneagnosia is equal to Balint syndrome, छोड़ के एक विजन रहता है गन बैरल विजन. गन बैरल विजन कभी कभी क्या होता है, पेरिफेरल फील्ड इन्वॉल्व हो जाती है, इन्फैक्ट हो जाता है, सेंट्रल फील्ड छोड़ देते हैं, तो इसलिए गन बैरल के जैसे उतना ही दिख रहा है, इतना दिख रहा है बस. सो दिस इज ड्यू टू bilateral P2 segment occlusion. Now coming to the last part. टिप ऑफ बैसिलर सिंड्रोम, टिप ऑफ बैसिलर सिंड्रोम, अगर यहाँ पे ऑक्लूजन हो गया तो पूरा सेम थिंग एज इफ इट इज बायलैटरल P1 सेगमेंट एंड P2 सेगमेंट सब चला गया, बायलैटरल P1 P2 एवरीथिंग ऑक्सीपिटल सब, इट्स ए वेरी कैटास्ट्रोफिक सिचुएशन, सडन ऑनसेट कोमा और स्टूपर, quadriplegia, upper motor neuron type, bilateral ptosis, midbrain गई, ओके, डिसेरिब्रेट पोस्चरिंग, सब कॉम्बिनेशन कर रहे हैं अभी क्योंकि सब सेम ही हो रहा है गणित के हिसाब से, पोस्चरिंग, डिसेरिब्रेट पोस्चरिंग, एंड वन इम्पोर्टेंट थिंग इज इट कैन बी समटाइम्स एसोसिएटेड विद सीजर्स, myoclonic seizures, myoclonic jerks. Any patient who is suddenly losing consciousness and is throwing myoclonic jerks with cranial nerve palsy, ptosis, immediately cerebral angio, MRI angio, and tip of basilar occlusion should be ruled out because this is one area where emergency thrombectomy करना है, catastrophic situation. So this is in gist posterior cerebral circulation.